Sorry, sir.
Sir, good evening, sir. No problem, sir. You have 2 minutes. You are on time. Pakka.
Left kai marakkudhu arth sir.
Ipa sir. It's okay, sir.
You are good, sir. Pakka, sir. Sanket, are you with us?
Yes, sir. I'm here, sir.
You want to try now?
Yes,
Share
sir.
your PPT.
Yes, sir.
Professor Erbas Moment, sir. Good evening, sir.
Hello, good evening.
We have Shanai sir also joining. Kanna sir is joining. So, good evening, sir. Good evening, sir.
Good evening. Good evening.
I warmly welcome all the faculty here. Today we have the honor of having Professor Erbas and Professor Dhyaneshwar both from Mumbai. And we have Professor Arasu sir from Chengalpattu Medical College. Again, I wish on behalf of all of you, Professor Arasu sir, for being appointed as the head of the PG board, PG Medical Board, Education Board in the Tamil Nadu MGR Medical University. Congratulations, sir, for this rare honor for a surgeon.
Thank you, sir. Thank you, sir.
And we have our senior faculty here, Professor Kanna sir, Professor Shanai sir, Professor Srinivasan sir, Professor Karnakaran sir joining. And I should also thank two important persons. One is Professor Amit Khanna, Amit from AIMS Rishikesh, for kindly contributing Dr. The Sanket Edam. And the other student is kindly contributed by Professor Kalevani ma'am, Dr. Abdesh. So thank you all the faculty. I'm sure all of them, all the senior faculty have been here already. So the first candidate will be presenting Dr. Sanket. He'll be presenting a case on, I would request people who are not dressed properly to stop their video, else I will be forced to remove you, sir. So I herewith start the first case for the discussion. Faculty, kindly permit them to run through the history part without stopping. Once they summarize the history, you can revisit slides from 1 to 3 and give your comments and questions. Same way, they are allowed to go through the clinical part without stopping. Then once they complete the clinical part, please go back to all the slides and give your questions and other things. So all the invited faculty take priority first, and then our own faculty are always there for the past 300 plus cases being discussed. They will be also giving their comments. Thank you, and we wish good luck for both the postgraduates. And I am sure it will be a lot of learning. And I also warmly wish the students who are in the YouTube live. Thank you very much. Abdesh, good luck to you. Please start your presentation. First, introduce yourself, your unit chief, and then your head of the department, and start your presentation.
Good morning, respected faculties. I'm Dr. Sanket Edam, junior resident from the Department of Surgery, AIMS Rishikesh. My unit head is Professor Amit Gupta, sir. And my guide is Dr. Deepa Raju, sir, Associate Professor, Department of General Surgery, AIMS Rishikesh. Sir, can I go ahead?
Please, ma, please go ahead. Good luck.
Okay. Thank you, sir. I present to you a case of a 24-year-old male student, resident of Bijnor, Uttar Pradesh. He presented with chief complaints of swelling in the left leg since the past 2 years. History of presenting illness. Patient was apparently well 2 years ago when he noticed swelling in the inner aspect of the left leg. It was insidious onset and gradually increasing in size from initial size of 1 into 1 centimeter to current size of approximately 18 to 7 centimeter, not associated with pain or fever. It is also not associated with any overlying skin redness, ulceration, or discharge. It's not associated with restriction of movement. There's no history of similar swelling elsewhere in the body. There's no history of trauma to the affected limb, no history of radiation exposure or chemical exposure. There's no history of numbness, paresthesia, edema, or weakness. There's no history of bone swellings. There's no history of unconsciousness, headache, seizure episodes, or blurring of vision. There's also no history of shortness of breath, cough, hemoptysis, or chest pain. There's no history of loss of appetite and weight. There's no complaints in the opposite limb. Past history, there's no history of similar swellings in the past. Patient does not have any comorbidities. There's no history of past surgical intervention. There's no history of any malignancy or similar swelling in the family. Personal history. Patient has a mixed diet, appetite is normal, is a non-smoker, and the occasional consumption of alcohol. Sleep patterns are normal, bowel and bladder habits are also normal. Summary, 24-year-old male with no comorbidities presented with pain and, sorry sir, 1 second. A 24-year-old male with no comorbidities presented with painless swelling in left leg for 2 years, gradually increasing in size from initial size of 1 into 1 centimeter to current size of approximately 8 into 7 centimeter, not associated with pain, fever, with no history suggestive of distal neurovascular deficit.
Sanket. Sanket.
Yes,
Can you go
sir.
to your first slide, please?
Yes, sir.
Okay, so, right, next slide. Not associated skin redness. Just go back, please. Ulceration or discoloration.
Discharge.
Why did you ask for this skin redness, ulceration, discoloration?
Sir, skin redness, I asked because I wanted to know if there's any inflammatory pathology involved, sir. I asked about ulceration to know if there's any pressure effect, causing ulceration of the growth or any other.
Sorry, does any pressure effect cause ulceration?
So the pressure effect on the skin causing ulceration.
Look, Sanket, what I'm trying to say is that you have to take history of congenital, traumatic, inflammatory, and malignant separately. You can't club the thing together, right? Your ulceration, you wanted to talk about malignancy, right? Or whatever.
Yes, sir.
So you can't club the thing together. You have to separate
Okay,
the history of all this etiology, right? Next slide.
okay, sir.
Now, your first, this thing is not a restriction of movement of leg. Your first line, is that very important?
Sir, it is not very important, but we'd like to know if the joint.
Right. Right. If whether the joint is involved. But that comes
sir.
much lower down. Now you have to find out whether he's got any predisposing factors for malignancy.
Yes, sir.
Then there are any other swellings, whether the swelling is benign or malignant by your history, right?
Yes, sir.
And then comes whether the lump is affecting the neurovascular system, the joints, all that kind of thing. Okay. So you just, the whole thing is just shuffled around. We are not getting an idea. What are you trying to achieve? Tell us. That's what it is. Your history should be complete for congenital, traumatic, inflammatory, and then malignant. They should be separate. So please. Okay, let's go to your next slide then.
Sanket.
Right.
Yes, sir.
So please.
One way I used to teach students is you just have any swelling you have anywhere in the body. You just approach in a fashion. The idea of somebody says swelling in the limb for 1 or 2 years anywhere in the body, I usually teach you just always ask, is it related to swelling? Then I tell, is it related to loco-regional effects of the swelling? Then you ask about, is it related to the systemic effects or metastasis and relation, and is it related to functional alteration secondary to the swelling? Any factors which can contribute to etiology. So if you divide history in that pattern, you start from the swelling, then go to the loco-regional part, what effect it has got on the loco-regional part. Then you go to the systemic part, what other effects it has got on the systemic part, either because of metastasis in case of malignancy or because of its systemic spread in certain diseases. And is there, next part I usually say is functional alteration. Take instance thyroid. You have hypothyroidism or hypothyroidism that comes there. And then etiology, as Sir rightly said, what is the probable etiology on the basis of history? You can come and arrive at any etiological factors that can contribute. And rarely in case of hernia, which is also a swelling, you just ask about anything which precipitates a particular swelling. So if you go in that order and you put your slides in that order, you go locally, then go loco-regionally, then go systemically in that fashion. Any books describes like that. And it is easy for us to follow also. Start from one point. This is my way of teaching. You will not miss anything. You will not miss anything. You have put everything, but as said, it is jumbled here and there. But otherwise, it's almost a very complete history. Thank you, sir.
Okay, just go back to your previous slide, Sanket, please.
Yes, sir.
Okay, now this swelling, you want to find out whether there is any neurovascular. So you asked about neurological, but there's no mention about any vascular history.
Sir, I asked if there's edema.
But it doesn't show anywhere.
Sir, it's written, sir, edema. There's no history of numbness, paresthesia, edema, or weakness.
Okay.
Edema could be okay, but vascular involvement is just more than edema, isn't it?
Sir.
That would be just a pressure effect on the veins or something.
Veins, yes, sir.
Right. So vascular, how would you take the history of vascular involvement?
Sir, I'll ask her if there's any edema or if there's any discoloration of the toes distally, any discoloration of the limb or toes distally for arterial, and for venous, I like to take history of edema.
So pain on walking, pain at rest, all that, right? All that has to come.
Yes,
right.
Okay, Sanket, I have a few questions to you, Dr. Rajgopal Shina here.
Good evening, sir.
Yeah, good evening. I just want to ask you, you have been told that this is a soft tissue tumor. This is how you people take this in this presentation. Now, if this boy comes to you in the fresh, you don't know, he has got some problem in his thigh or whatever inner aspect. How do you think first, as has been already given you some hints, congenital, traumatic, all that thing. He is 22 or something like that, correct? No, young boy.
Yes, sir. Yes, sir.
So where do you put the trauma in this patient in the order? This is my first question.
Sir, trauma would be first, sir. Trauma would be initially.
Then why did you put somewhere in the second slide? Correct?
Yes.
Always, whenever you have a limb problem, whether it's a foot or a thigh or a swelling, young boys, they are all this jumping and this group. So some trauma should always. Do you know any relationship to trauma to your case?
No, sir.
I don't know whether it's a soft tissue sarcoma tumor. I have no idea. But how do you correlate at the end? Do you have anything, or just a incidence, just a coincidence?
Sir, usually the patient, it's not an etiological factor, sir, but the trivial trauma can make the patient more attentive towards the growth, sir.
That is, I accept that. Number one. Number two, can you think of any other lesion in the thigh like that, slow growing? Some hint has been given to congenital. Does not mean that you see only in the newborn. You can go like this for 2 years, slowly increasing in size. How do you make sure that when patient is straight away went in for headache, seizure, episode, blurring of vision? I will ask you one more question. What else you can have a congenital lesion in the thigh like this, slowly growing like this, can attain a reasonable size?
Yes.
Benign. What is that?
You can have AV malformations.
Why not? Why not? You can have a local gigantism, local increase in the size. It can have some distal ulcers, distal edema. What I'm trying to tell you is, how did you take it for granted that it is, according to it's a slow growing, correct?
Yes, sir.
There's no rapid increase at all, correct?
No, sir.
So it's better that you take it in this way rather than put it. So long as your trauma is correct, you have written the incidence also I have seen. So you don't have to go up to this level of those things, to loss of appetite and loss of weight. Is it that usual manifestations you get in soft tissue? So it can also be very well a benign tumor, slow growing.
Yes, sir.
Neural tumor. You have mentioned about paresthesia, inner aspect of the thigh. Of course,
sir, sir, inner aspect of the leg, sir.
Inner aspect of the leg.
Okay. Yes, sir.
Okay. So radiation exposure, what is that you want to ask? Radiation exposure, you have written there, correct?
Yes, sir. Yes, sir.
So what?
Sir, radiation patient with, usually if we suspect radiation, patients with radiation exposure have 8 to 50% increased chance of having soft tissue sarcoma, sir, especially if the patient has had lymphoma or breast cancers.
For this case, I would have probably put it better rather any skin lesions, whether the patient has noticed to know K-Phyllis spots. What is that K-Phyllis spots indicative of? If patient has got some K-Phyllis spots with this
Yes,
problem,
sir.
what is that?
We'll
Yes.
think of neurofibroma, sir.
Neural tumors rather
Neural
than.
tumors.
So these are just a few my comments, sir. Please, sir.
Right. Sanket, let's come to your
Yes, sir.
differential diagnosis.
Say it's not presented.
What's the
Sir,
differential diagnosis?
Sir, according, based on the history, sir, I would consider a benign lesion, sir, most likely a lipoma. Lipoma would be my first differential, sir. Based
Then
on the
what
history.
else? Okay, what else?
Lipoma and epidermal inclusion cyst would be another type of differential, sir.
Epidermal inclusion cyst in, okay, or maybe. More, give us more common ones which a young boy will present.
Sir, I would think of hematoma. Yes, sir.
Right, a hematoma.
But the patient does not
Chronic
give any history of
hematoma, a
trauma, sir.
lipoma.
Yes, sir. Yes, sir.
AV malformation,
AV malformation.
hemangioma,
Hemangioma.
right?
Yes, sir.
Lymphangioma, these kind of things, benign conditions, right? And
Yes,
a cold abscess.
Cold abscess, yes, sir.
Right. So,
yes, sir.
So I think they should be much higher on your list. So anyone else, sir, please? Or should we go to the examination?
Sanket?
Yes, sir.
What is hamartoma?
I'm sorry, sir.
What is hamartoma?
Sir, hematoma is it's a type of AV malformation, sir.
No.
Sir, what do you say?
I'm sorry, sir. I'm not sure.
Yeah. Hamartoma, as my teacher used to say, is missing the mark in spear throwing. Just to say,
Yes.
a cell has
That's what hamartoma means. If you throw a spear, it misses its mark.
Yeah, a cell has to differentiate in a particular line. All your lymphatics, arterial, venous system, everything differentiates from a common mesenchyme. When a particular differentiation fails, you start having a tumor which does not have a single cell line. It mixture of tissues which ultimately lead to a soft tissue tumor. That is why your lymphangiomas and AV malformations, they are mixed. In some situations, you have both mixture of lymphatics as well as AV malformation, arteriovenous tissue. So that is the one thing. So that's called hamartoma, is missing the mark in spear throwing. That means a particular cell line to which it is intended to grow is not happening. Sanket, I just wanted to say,
yes,
can you just rule out trauma by your history alone? Trauma is very common in that age group. Sir,
yes,
you can just argue with me saying, sir, because of this, I say this is not possible. Can you say that?
No, sir, we cannot say that. It would be a trauma which he would have not noticed.
I said you can say that on the history. How?
Yes, sir.
How? See, it started, you just put it as a swelling which has started as 1 to 2 centimeters and has progressed attained 8 to 7 centimeters. In over a period of 2 years. Is it common for a trauma to progress like that over a period of 2 years to achieve such a size?
No, sir.
Yeah, it is not possible. So it is not related to trauma. You can attribute it to trauma. In trauma, what has to happen has to be bigger in size, becomes larger and forms a seroma, it can be large. But can never a small swelling can gradually progress and attain the 8 to 7 centimeter size. Straight away, that etiology, you have a point to say that it may not be. It's very common, very, very common. Suppose if it is a trauma, its presence has a 8 to 7 centimeter swelling. What it could be? What it could be?
Sir, it could be a hematoma only, sir.
Yeah, what you call it? Can you call it hematoma after 2 years?
It can be a chronic hematoma, sir.
What it can lead on to in the limb, in the tissue, in the skeletal muscle? What is more common in the elbow region, which can cause stiffness after a post-traumatic fracture, supracondylar fracture in elbow region? myositis ossificans can, it can cause stiffness and can have hard consistency. Any inflammation, injury, hematoma, chronic inflammation can lead to myositis. Which is common. So it will have a hardness also. So in that situation, it is unlikely on the basis of history which you have given. Okay. Second thing,
calcified hematoma.
Yes.
It is a calcified hematoma is there.
Yeah.
Really present like a very hard tumor. Right.
What is the relationship between trauma and soft tissue sarcoma, as the book states?
I'm sorry, sir.
What is the relationship between trauma and soft tissue tumors?
So usually soft tissue trauma does not have any, it's not a etiological factor for soft tissue sarcoma, sir, but
actually
it usually gives the attention of the patient towards the growth, sir.
Exactly, but it is not say, the book does not say not related. There are no evidence to suggest that trauma. It doesn't say that the trauma does not relate, but definitely we are not accepting it. Second, it brings the patient to the hospital. So we will be biased, thinking and attributing a tumor and miss the soft tissue sarcoma. It may mislead, the patient may mislead us, and we will make a mistake. So that mislead should not be taken. You should take the clinical examination and process and proceed. Thank you, sir. Just I think you can proceed if everyone accepts to the next stage. Yes.
If there are multiple swellings on the body, like this is there, what will be your first diagnosis?
Sir, the multiple swellings of this size, I would think of I'll still think of lipoma only, sir.
So one is a lipomatosis, multiple lipomatosis is there. What are the other multiple swellings similar to that?
I'd think of neurofibroma, sir.
Good. Anything else? Any parasitic infection which can cause that?
I don't know.
I think of parasitic cyst. I think of parasitic cyst, sir.
Which one?
Cysticercosis, sir.
Cysticercosis. Good. Right. Okay, you can
if
go ahead.
Somebody has got cysticercosis, what symptoms you will ask in general systemic history?
I'm sorry, sir. I'm not sure.
It can go to neurocysticercosis. It may have multiple cysticercosis in the brain, which can present as starry sky appearance in MRI, which can produce fits and it can also cause seizures. Yes. Has caused a focal neurological deficit also. Yes. Is it common in vegetarian cysticercosis? Is it common in vegetarians? They used to say beef eaters and pork eaters.
Yes.
Is it common in vegetarians? Can it happen in vegetarians?
It can happen, sir, but it is.
How? It is related to eating salads.
Salads.
Yeah, the vegetables which are not washed and they're taken salads which are not hygienically served. It can lead on to even common in vegetarians also. Usually, beef and pork is a source for this infection. Proceed. Yes.
General physical examination. The patient was conscious to time, place, and person. Patient is moderately built and well nourished with adequate hydration. Pulse rate of 96 minutes in the right radial artery. Blood pressure of 160/72. Measured in supinposition in the right arm. Respiratory rate of 18. Saturation of 98% at room air. And patient is febrile. Patient has a height of 149 centimeters. Weight 51 kgs. BMI of 23 kg per meter square. ECOG of 1. No pallor, icterus, cyanosis, clubbing, edema, gentleness, lymphadenopathy was noted. On inspection, the patient was examined in a well-lit room, stripped from umbilicus to down. The gait of the patient was normal. The right lower limb appears unremarkable. A swelling of size approximately 9 to 10 centimeters presents on the left upper leg. The superior border of the swelling is 8 centimeters from the medial tibial condyle and inferior margin is 15 centimeters on the medial malleus of the ankle. The medial border is 2 centimeters medial to the shaft of tibia. The swelling is ovoid in shape and surface appears lobulated.
Always say never strip. Always say better word is exposure.
Exposed. Yes.
Never say strip. Okay. Better avoid this terminology. Patient is asked to expose. Asked to expose. Asked to expose from the region. Never say strip. Okay.
Okay. Margins are well defined. There's no visible pulsations. Overlying skin appears normal with prominent vein and no hair loss. Swelling appears prominent on plantar flexion of ankle. There's no edema in affected limb and wasting of distal muscles of left lower limb. No pigmentation, sinuses, scars were found. No visible swellings in the groin. Palpation, local rise of temperature was swelling. There's no local rise of temperature. That was non-tender. Inspectory findings were confirmed. The surface was lobulated with firm consistency. The margins were well defined. It was non-pulsatile and not fixed to the overlying skin. It was mobile in both directions in relaxed position. Restricted mobility on plantar flexion of left ankle joint. There's no regional lymphadenopathy noted. A girth of 27 centimeters on the left side and 21 on the right side, measured in the mid-calf. The sensory and motor system examination was unremarkable in both limbs. So image, sir.
Yeah.
And pulses, sir, all pulses were palpable in bilateral lower limbs. Systemic examination, cardiovascular examination, normal S1, S2 sounds were orderly.
Nothing remarkable. Yeah.
Yes, nothing remarkable, sir.
Okay. Which system would like to concentrate more in this CVS, CNS, respiratory, and abdomen?
So let's concentrate more on the respiratory system, sir.
And is to certain extent CNS. Okay.
CNS, yes, sir.
Yeah, respiratory predominantly. Okay, right then.
So DRD was unremarkable.
Okay.
Summary, sir. 24-year-old male with no comorbidities presented with painless swelling in the left leg for 2 years, gradually increasing in size from initial size of 1 into 1 centimeter to current size of approximately 18 centimeters, not associated with pain, fever, with no history of suggestive of distal neurovascular deficit, lobulated surface, firm in consistency with restricted mobility on plantar flexion, and with no inflammatory signs, with no sensory or motor deficit in affected limb.
Okay, Sanket, just go your regional examination. Did you see look for the gait of the patient?
So the patient came walking, sir, to the OPD. He was, yes, sir.
That is fine, but even if he's walking, there could be some problem with his gait.
It was normal, sir. I've seen it.
But you've not mentioned it.
Sir, I wrote it's a gait of patient is normal.
Okay, right. And what about his joint movement?
The joint was freely movable, sir.
Range of movement is normal in all the joints?
Yes, sir. Range of movement is normal on the joints.
Which joints have you tested?
Sir, I've tested the ankle joint and the knee joint.
Let's see. Let us have a look. No, let's have the ROM of the joints.
Sir, I've not mentioned it here, sir.
Okay. What about what sensations, sensory examination have we done in the lip?
Sir, I've done fine touch, sir, crude touch, and pain, sir. Pain and temperature.
Let's have a look. Where have you written? Have you written this?
So sensory and motor system examinations unremarkable in both the limbs, sir.
Look, you can't. This is a limb case, no? So you'll have to break it up. What are the sensations which you look for? Sensory. What sensory examination do you do?
Sir, we look for
fine touch.
Fine touch, crude touch, temperature, pain, pressure, sir.
Joint position and vibration.
Vibration. Yeah.
Okay. And what about motor? How did you examine for which muscle system is being involved? How do you know which muscle system is being involved? Is it involving only one? What are the what? It's in the leg. Let's go back to the picture. How many compartments in the leg?
Sir, in the leg, sir, the 3 compartments, sir. The posterior compartment, the superficial and deep compartment.
Hang on. Yeah, which are the 3 compartments?
Sir, 3 compartments, sir. Anterior, lateral, and posterior has 2 compartments, sir. Superficial and deep, sir.
So which compartment do you think is involved here?
Sir, here I feel it is a posterior compartment only.
You got to look, son. Is it below the muscle? Is the muscle involved? Which compartment is being involved? Because your whole surgery management depends on this now.
Yes, sir.
Isn't it? So you have to test the muscles. You have to find out whether the muscles involved, whether the fascia is involved or not.
So the muscle was involved, sir. Sir, I did. Sir, most likely
muscles here on the medial side.
Sir, on the I'm sorry, sir.
It's a medial lateral. It's on the medial side or lateral side?
So on the lateral, on the anterior compartment, so there's tibialis anterior, extensor hallucis longus, and extensor digitorum longus, and the lateral compartment there is peritoneal longus and peritoneal brevis. In the posterior superficial compartment, so there's gastrocnemius and soleus, and deep compartment.
That's fine. But which muscle is involved here now?
Sir, here I feel that gastrocnemius is involved, sir.
You feel this is the medial side, isn't it?
Yes, sir.
So where's the gastrocnemius?
So it has two. The medial head. We feel that the medial head of the gastrocnemius is involved, sir.
This is, you've got the sharp margin of the tibia.
Yes,
is it anterior to that sharp margin or posterior to it?
It's posterior, sir.
It's posterior. So then that's why. So you should mention that. No, you've not mentioned which muscle system is being involved.
Mentioned it here.
Which muscle system? Come on.
Sir, I've written that it is 2 centimeters medial to the.
You're just describing the position.
Yes, sir.
You're just describing the position. You're not telling us the level, the depth of the tumor. Where have you, by your examination, where have you said that is what is the depth of the tumor?
So swelling appears prominent on plantar flexion of the ankle, sir. And on palpation, sir, this mobile in both directions in relaxed position and restricted mobility on plantar flexion at the left ankle joint, sir.
Sanket, you're missing the point, Sanket, please. We want to know whether a single compartment is involved or a multiple compartment is involved. Whether the bone is involved, whether the nerve is involved, whether the artery is involved, whether the vein is involved. By your examination, you have to come up with all this.
Yes, sir.
Sir, please.
Sanket,
Yes,
you have started examining a swelling which is on the medial aspect of left lower limb. Is it right?
Yes, sir.
Yeah. And what is that as you start examining, and what is that you want to establish? Plane of the swelling, is it not?
Yes, sir. Yes,
What is that criteria? Why is it important for you to describe the plane? Why is it important to describe the plane of the swelling?
Sir, it is important because we need to know from where it is arising. Is it from the skin? Is it from the subcutaneous, or from the fascia, or from the underlying muscles? Sir?
Absolutely right. So what are the chances of the particular tumor in question being malignant? If it is above the fascia or below the fascia?
So below the fascia, it is more likely that it is malignant.
More, yeah. Anything which is deep to the deep fascia has got a higher chances of it being malignant. Okay. You have to rule out malignancy if anything is deep to deep fascia. But
Yes,
if it is above the deep fascia, what is the size? Is there any size criteria?
Sir, usually less than 5 centimeters.
Fantastic. Absolutely right. Any swelling which is more than 5 centimeters, suprafacial or above the fascia, or all deeply situated swellings deep to the fascia need to be imaged and biopsied.
Yes, sir.
Anything which is less than 5 centimeters, 2-3 centimeters above the fascia, you can do a wide local excision or excision biopsy after FNAC. But anything which is deeper than that, size criteria is not very strict. You have to suspect malignancy and you have to do a biopsy before proceeding. The chances of the particular swelling being high, the malignancy is very, very high. In your presentation, I think you can just go from inspection, Shaket, if you don't mind.
Yes, sir.
Go to that. And you have just mentioned ovoid in shape. Suppose appears lobulated. Will it be a case it's deep-seated swelling? Can you see a lobulation if a swelling is arising deep to the fascia and the tough fascia is over that? Is it possible? It is not a feature. It is not possible. It is arising from a bulk of a muscle. You have a tough fascia on top. The lobulation is a feature of a swelling which is present very superficially or it's got a very thin muscle. In thyroid, you see lobulations because you have thin muscles. but not in a limb with a bulky gastrocnemius. You will not be able to see. The ovulation is usually a feature of deep superficial swellings, especially of this size. You are contradicting that point. If you say that it appears to be like a lipoma, second thing,
yes,
that you're leading on that point actually. And go to the next slide. And well-defined margins, and you have put on a lot of things. And putting the plantar, what is the function of gastrosoleus?
sir. It is plantar flexion of the ankle, sir. Flexion of the ankle, sir.
Plantar flexion through the tender Achilles, powerful plantar
Yes.
flexion of the ankle.
Mhm.
Okay, right. You said you have no visible swellings in the groin. Why did you mention that point, Sanket?
Sir, I want to see if there are any lymph nodes, enlarged lymph nodes present, sir.
Is it common?
It is not common, sir, but it can happen, sir, in a few types of sarcomas.
Can you say that? You want to lead us to that point? Can you say that?
No, so even if there's any, even if it is any infective pathology or any other malignancy that would spread to the lymph nodes,
Do
sir,
you still suspect infective pathology in this
no,
tumor?
sir, I don't.
You have
No,
gone
sir,
to
I
an
don't.
examination, examined, deep-seated, deep to the muscles, 8 centimeters, with 2 years history. Do you still want to stick on to infective pathology?
No, sir. No, sir. I'd still think of.
As you progress on inspection and examination, you should more categorical in your diagnosis. This is
Yes,
not
sir.
the case as it turns. What are the sarcomas that spread to?
Sir, rhabdomyosarcoma, clear cell sarcoma, angiosarcoma, and synovial sarcoma can spread to the lymph nodes, sir.
Yeah, you just mnemonic scream. Scream is the mnemonic. Scream. Synovial sarcoma, clear cells. You can read any book. Suppose if the lymph nodes are involved in a epithelial malignancy and the soft tissue malignancy, what is the difference in the grade of and staging it makes between epithelial malignancy and a mesenchymal malignancy node involvement?
Sir, in mesenchymal malignancy, if the lymph node is involved, it directly see upstage to stage 4, sir.
Absolutely fantastic. It upgrades straight away,
Okay.
not like your epithelial tumors like breast and thyroid. It upgrades the tumor into stage 3, stage 4 straight away. They don't spread. It's got a very poor prognosis if there are nodes involved. Next slide, Sanket. Next. You said firm and consistency. Okay, next.
Yes, sir.
Previous one. Sorry, previous one. Okay. Next slide.
Sanket, which nerve do you think would be involved if it was involved? What is the nerve of the posterior compartment?
Sir, nerve of the posterior compartment is posterior tibial nerve, sir.
Which nerve?
Tibial nerve, sir.
Tibial, yes. It's tibial nerve.
Can you trace
Would you test for... Sorry, sir, please.
No, nothing, sir. What are the nerves in the posterior compartment?
So, in the posterior compartment, sir, the sciatic nerve comes and divides into tibial nerve, sir, that goes in the posterior compartment, and common peroneal nerves goes in the lateral compartment, sir. And there it gets divided into superficial and deep.
This is the zone of tibial nerve or peroneal nerve?
So this is zone of tibial nerve, sir. No, peroneal nerve is laterally.
Okay.
Sanket,
just can I know the extent of this, whatever you have written? Just go back under palpation. Extent.
Well,
See, this is not the way you present palpation. Just go back. Yeah. So
yes.
Local rise of temperature, all that is fine. See, you can't say that straight away inspective, because remember, we are, as a surgeon, if you are suspecting soft tissue sarcoma, this is what is very important for us. I will not describe this in relation to the ankle joint and medial malleolus. Number one, what I would like you to understand is, from the whatever you are talking about knee joint, we are not able to see it properly. So that's why all this. So it's a more of a, I understand it's like a laterally and posterior, medial side. Correct? Correct. Where is this lesion?
Medial side, sir. Medial side, sir.
Skirting little posteriorly. Only edge
Yes,
of the
sir.
gastrocnemius is there.
Yes.
So what I will explain, imagine is probably from the tibial condyle you are written. How far from the shin of the tibia? You understand, no?
Yes, sir. 2 centimeters, sir, from the shin of tibia.
There should be a very clear gap there.
Yes, sir.
How far going behind? Behind means From the medial side, it is slowly going behind.
Behind, yes, sir.
You have shown two pictures, correct?
Yes, sir.
So that will give us some idea that which muscles are involved. This is how we should
Yes,
go ahead. And then that is one thing. So extent of any of these swellings, especially malignancy, you have to be very clearly mentioned. Extent.
Yes, sir.
That is a very important point, because whether you are taking local wide excision, whatever it is, that is important. You have written one prominent, one single vein is seen. What is
Yes,
that?
sir. Sir, it could be GSV, sir.
Yeah, so it could be that it's
GSV.
pushing. Hello. And one more thing, just
Yes,
go
sir.
to the next slide. Next slide. Yeah, whenever you have written this, when plantar flexion of the joint, mobile, that is all fine. Here you should add one more word. It becomes more prominent or less prominent.
Prominent. Yes, sir. It becomes. Sir, I'm not able to hear you. Sir.
Hello, somebody is.
Yeah.
So what I want you to understand is on contraction of the whichever muscles which you have mentioned there, on
Yes, sir.
plantar flexion, mobility gets restricted in whichever direction, and the swelling becomes more prominent,
Prominent.
or less prominent. Obviously, more prominent looks like
Prominent.
your case. It gives
Yes,
an
sir.
impression it's a subcutaneous swelling.
Subcutaneous. Yes, sir.
That is how we have. And when they contract it against surface, you feel properly, because then it becomes more prominent. You can appreciate whether it's whatever you want to call, like as it's been clarified to you, nodular or whatever it is, lobular. So that can be mentioned at this stage. These are my few observations. Thank you.
Sanket, in your
Yes.
example, the pulse,
You can process. Okay, right.
in the pulse, you said
Yes, sir.
1 plus all pulses. So what does that mean?
Yes, sir. Sir, all pulses were equally palpable, sir. All pulses were palpable and they were good volume, sir, in all the pulses.
So if you are putting just 1 plus is there, is that a good volume pulse?
No, I should have put 2, sir.
Yeah, all should be 2 plus. No.
2 plus. Yes, sir.
When you say it is 1 plus, it is feeble pulse.
Feeble pulse. Yes, sir.
Minus is no pulse.
No.
1 plus is feeble. 2 plus
Yes,
is
sir.
not. And
Yes.
3 plus is bounding pulse. You know?
Yes, sir.
Where do you feel the dorsalis pedis artery?
So dorsalis pedis is
Okay,
spelled,
Sanket.
spelled lateral to
Is
the
that
external hallucis longest tendon, sir.
Where? Where?
Sorry, sir?
Where
So
do
between
you said the lateral to the external hallucis tongue that goes up to the digit?
in the upper parts, in the upper third, sir, of the first and second metatarsal, sir.
Against which bone you feel that?
Against the first metatarsal, sir.
No, you don't feel it against the first
Second.
metatarsal. What are the bones of the foot?
Bones of, sir, the metatarsal, sir, and calcaneum, navicular, cube. I'm not sure, sir.
Okay, so you feel it against the navicular and the intermediate cuneiform. Okay, it is not felt against the metatarsal. You feel it in the first metatarsal space,
Yes.
but against the navicular and the intermediate cuneiform bone. Okay. And where do you feel the posterior tibial?
So
Against-
posterior tibial. So posterior tibial is felt between the medial malleolus and the Achilles tendon, sir.
Against which bone?
Against the tibia, sir.
Tibia.
Against the medial malleolus, sir.
It's a large bone of the foot.
Large bone.
Hmm.
Against the calcaneum, sir.
Against the calcaneus, not against the
Calcaneus. Tibia. Against the calcaneus, sir.
And where do you feel the anterior tibial?
Sir, between the medial malleolus and lateral malleolus along the lower border of the tibia, sir.
Yes. Okay.
Okay, I think 15 to 20 minutes left. Can you go to your differential diagnosis?
Yeah, I just wanted this is Dr. Sai. I just want to ask him. You said it's involving the muscles of the posterior compartment.
Yes, sir.
Right. So how do you test for the muscles of the posterior compartment? How do you make them? How do you test for them?
Sir, posterior compartment help in plantar flexion of the ankle joint, sir. So against resistance, I would ask the patient to plantar flex, sir, the ankle joint.
Right. So what were the muscles which you tested? What are the superficial and the deep muscles there?
So the superficial muscles are medial and lateral head of gastrocnemius, sir. The deep muscles, deeper to that is soleus, sir. Deeper to
superficial
that,
are? No, hang on. Superficial are?
gastrocnemius, sir, followed by soleus, sir, followed by,
right.
Yes.
Yeah, plantaris, which is absent in 10%. Right. And what are the other,
Yes.
the deep muscles there?
Sir, the other deep muscles are tibialis posterior, sir, extensor, extensor hallucis longus and extensor digitorum longus, sir.
Okay, right. That's fine. So, please, sir.
So can you go to your differential diagnosis, Sanket? 15 minutes left. We need to finish. Yes, proceed. What is your differential diagnosis? Proceed. Yeah, anything to offer?
Sir, my differential diagnosis, sir, for this patient after history and examination, sir, my first differential would be soft tissue sarcoma, sir, as it is arising from the
benign or malignant?
Malignant, sir.
Why?
So because it is the consistency is firm, sir, and it is arising from the deeper plane and most likely from the muscle, sir. So in my first diagnosis would be soft tissue sarcoma.
Which category will be categorized it on the basis of the history which you have? Low grade, intermediate grade, or high grade?
Based on the history, sir, it would be low grade, sir.
Why?
Because the patient already, it has been 2 years, sir, and patient did not develop any symptoms.
Good. So slowly progressing swelling.
Slowly progressing swelling.
Slowly progressing. Sorry, how will you confirm your diagnosis? You made a provisional diagnosis of a soft tissue tumor, most likely to arise from the gastrocnemius soleus complex, which could be arising either from it or muscle proper, or could be arising from the sheath or the fibrous tissues surrounding along with it. How will you fix the diagnosis?
Sir, I would initially confirm my diagnosis, sir, by MRI, sir, followed by core needle biopsy, sir.
Okay, MRI. Why is it MRI, not CT scan?
Sir, MRI is better for it's better for delineation of soft tissues and it's better for delineation of muscles, vascular structures, and the bone. And CT scan is better in the abdominal parts, for abdomen, sir.
Any other thing can be added in MRI if you want to do further?
I'm sorry, sir. See, MR angiography can also be added, sir, if we think the vessel is involved.
The tumors, you can add MRA.
Okay.
It help in resection post once you plan for surgery. What biopsy would you like to do?
Sir, I'd like to do core needle biopsy, sir, from the lesion.
A true cut biopsy. What is the size of the needle in general?
Sir, I'm not sure, sir. Sorry.
It is 14G. It's 12-14G, 14 gauge needle. It's used. You like to do straight away biopsy, or you want to take somebody's help in doing this biopsy to increase the...
Sir, we can do an image guided biopsy, sir, to avoid any necrotic tissues.
Yeah, because of it's almost becoming a standard practice to do, because striking a wrong area and not making a diagnosis is detrimental to patient. It's better to do a guided biopsy. Yes, what pathology you like to expect in this patient? You have a disease, then you have confirmed it. What histopathological diagnosis probably could be in a 24-year-old man?
Sir, I would suspect liposarcoma, sir, in this patient.
In a limb, which is more common. Distal.
Sir, malignant histiocytic.
Malignant fibrous histiocytoma.
Fibrous histiocytoma, sir.
That was a diagnosis 25 years back when we are all. They said it is the most common tumor that is being deleted. It is not. It is not categorized into that. No, it is categorized one of the rare variety of MF. It's not a common variety. In a limb, in a young man, what is your suspicion, man?
Rhabdomyosarcoma, sir.
Yeah, that is what is the diagnosis. Liposarcoma tends to occur in a more proximal limb, such as thigh retroperitoneum. So, in a limb of this nature arising from a muscle, you cannot say liposarcoma, though it can you
Yes, sir.
understand? The first priority should be
Rhabdomyosarcoma.
sarcoma, most likely. And it could be anything, but in priorities, I am saying, can you understand? Liposarcoma,
Yes.
if it was thigh, I would have voted for liposarcoma followed by rhabdomyosarcoma. You click histopathology confirms it to be a rhabdomyosarcoma. What is your next stage?
Sir, next, sir, I would like to stage the disease, sir. I would like to get a CCT of the chest, sir.
Okay, then CT, ultrasound abdomen, and other working investigations you have done. Then you
Yes,
have
sir.
this, which is rhabdomyosarcoma. Notes are not there. CT does not show metastasis. Isolated disease. How will you stage and progress further?
Sir, I cannot stage the disease as grade. What is the grade? I'm sorry, sir. Have you told the grade, sir?
No, you have to tell me the grade.
Okay.
You have to take any grade which you like or different
Sir,
grades. Can you understand?
we cannot stage the disease without the grading, sir.
Yeah, you suppose you take a different size.
Yes,
you
sir.
have a size.
Okay, sir.
You have no notes.
Okay.
You have no metastasis. You put that into grade and tell me the stage according to the grade. Can you understand what is?
Sir, yeah, I understood, sir. If the grade of the tumor it's low grade, sir, then it would be stage 1A, sir. And if it is high grade, sir, then it would be stage 3A, sir, based on the size.
Yeah, on the base of size alone, grade alone you divide, or you have a combination of grade and size?
Both grade and size, sir.
What are the T? Can you just tell me the TNM staging for soft tissue sarcoma?
So TNM staging, sir, T1 includes less than 5 centimeters, sir. T2 includes 5 to 10. T3 increased 10 to 15, and T4 is greater than 15 centimeters, sir.
Okay. If you add grade,
Sir, if we add, sir, if we add
8 centimeter tumor is T2.
Yes, sir.
If it is G1, what is the stage?
So it will be 1A, sir. And if it is G2 or G3, it will be stage 3A, sir.
Yes, fantastic. Absolutely right. Take this as a case of stage one or stage
Yes,
2. Okay.
Yes, sir.
What will you do for this patient?
Sir, but stage 2, sir. Initially, sir, for this patient, I would like to give neoadjuvant radiation therapy, sir, followed by wide local excision, sir.
Why?
Sir, neoadjuvant, the radiation, a study done in Canada, sir, the only RCT shows that if the neoadjuvant radiation therapy has is better compared, it's not better, sir. They've told that there's a better, the amount of radiation, it's only around 50 grays, but post-operatively you'll have to give 60.
What is your institution practice?
Sir, institution practices radiation therapy after after wide local excision, sir.
When you do surgery first, there is no distant metastasis. There is no operable tumor which is preserved planes, and you can always excise the tumor in a limb without producing much compromise. It is not possible in a critical area. It's not a critical area of the limb. You have bulk of muscle. Primary surgery could be better than doing I think this is what I feel could be the stage. Have you heard of what is Kawaguchi equivalent?
I'm sorry, no, sir.
You don't know. My PG star taught me that, to be honest. So, you give a margin. Each tissue has got a margin. Go and read that. I just want to give it as a homework. Take 3 minutes for me to explain. Perineurium adventitia has got 1 centimeter margin. Thick fascia has got a 3 centimeter margin. Cartilage has got 5 centimeter. You can count on margin on the base of the tissue which take with the excision. Right. What will you do? 8 centimeter tumor G1 to 2. What will you do? Wide local. How much of margin you want to give?
1 centimeter, sir.
1 centimeter correct margin. Suppose if you have a tumor, liberally you can give. What safe margin you can give?
2 centimeters, sir.
Absolutely right. Fantastic. You've done your homework nicely. So 1 is good, 2 is excellent, 5 millimeter is poor margin.
Poor margin.
Or poor margin. So it's always 1 to 2 is considered as excellent margin. In this area, you can give wide local because what was originally practiced in a limb tumor of this nature, probably 10-15 years back, what was practiced? What type of practiced?
Amputations were practiced.
No, before that, in this area.
Isolated limb perfusions.
The criteria for amputation in the soft tissue sarcoma.
Sir, when the function cannot be preserved, sir. When function cannot be preserved.
You know,
and neurovascular.
they go with the criteria: tumor, node, metastasis, larger tumors with recurrent tumors involving multiple compartments, poor grade, undifferentiated pleomorphic sarcomas. These carry poor prognosis. So they need to be amputation. Compartmental excision. When we were all 20-25 years back, the involved muscle compartment will be excised from its origin to insertion. That is what it was originally practiced. But nowadays we don't do that. What we do is a wide local excision. Followed by what? After excision, what will you do?
So after excision, sir, I'll give radiotherapy, sir, to the patient. I am intensity modulated radiotherapy, sir.
Don't say that. I will send a specimen for histopathology.
Histopathology. I'm sorry, sir. Yes, I'll send it for histopathology, sir. And then I'll look for site. Yes, sir.
Assess a cell line. I'll confirm G status, grade status, and differentiation. Then we'll go for yes.
Yes, sir.
What type of radiotherapy?
Sir, I'd like to give intensity modulated radiotherapy, sir.
Okay. Yes. What is the principal shift in the treatment of soft tissue sarcomas from 20 years back and now?
Sir, it is more limb preserving surgery, sir.
Absolutely fantastic, Sanket. Principle is very good. Limb preservation. Even if it is very close to a bone or a vessel or a nerve, you can shave excision can be done. You can give IMRT and chemotherapy so that functionality has given more gain, more important than radicality over a period of years in any organ, more in soft tissue sarcomas. Nobody does soft tissue sarcoma except for the reasons sometimes I mentioned. Okay. But you can, any chemotherapeutic agent or anything can be of use?
Sir, chemotherapeutic agents can be used if the tumor is chemosensitive, sir, like synovial sarcoma or round cell liposarcoma. Usually doxorubicin-based therapy or iposamide-based chemotherapy is given.
Doxorubicin, dacarbazine, ifosfamide. Okay. What is synovial sarcoma? You just made a mention. Is it common in this area?
No, sir, it is not common in this area.
Okay. It can arise closely from a muscle or from a
muscle.
Okay. It will not be from synovial tissue proper. It can arise from anything musculoskeletal close to tendon sheath. Okay. What do you expect the prognosis? Yes, sir.
Sorry, sir. Professor Dhyanish had to leave after the first case. Can I take comments from him, sir?
Yes, sir. Sir, please,
Professor
sir.
Dhyanish, sir, please.
Can you hear me?
Yes, sir, I can hear you, sir.
Okay. Suppose you said you will be taking biopsy, right?
Yes, sir.
Okay. Suppose it shows schwannoma.
Yes, sir.
Okay. So what will be your plan of action?
So,
will it change how you should go ahead?
Yes, it will change the management, sir.
So what will you do?
Sir, I would. Sir, I'm not sure, sir.
Not sure. Okay. Will you be doing the similar excision, or you will be doing some radical excision, or anything else you will be doing? Any idea how you handle the schwannoma?
No idea, sir.
Any role of any chemotherapy or anything as such? Radiation therapy?
Sorry, sir, I'm not sure.
Okay. Now, in your presentation, you mentioned about initially very first, right? It could be a simple lipoma also, right?
Yes, sir.
Because it was mobile in both the directions. And finally, you have given the diagnosis of liposarcoma.
Yes, sir.
Because it is a little firm.
Yes, sir.
The consistency. So, what do you feel it is really? Is it a lipoma simple or is it a liposarcoma?
No, sir, I still feel it's a liposarcoma because it is firm in consistency and it is coming from the muscle, sir. Coming from the deeper plane and arising from the muscle.
Okay. And how have you ascertained from which plane it is coming?
Sir, I asked the patient to plantar flex the ankle, sir, against resistance. So the swelling was firmly fixed to the muscle, sir. It was not mobile, sir.
No. Was the size changing?
There's no change in size, sir.
so that it shows what it is in the muscle, beneath the muscle, above the muscle.
Sir, if it was beneath the muscles, if it was beneath the muscle, it would have completely disappeared, sir. If it was above the muscle, it would become more prominent, sir.
You said it is the same size.
Yes, sir.
So
relatively, yes, sir.
Okay. Okay. So I just want to suggest one thing. Everyone has commented very beautifully, and you must have received a lot of inputs. But important is that you have to keep your vision open and to suggestions. Don't even if the expert in the exam tells you that this is so and so case, do not get blinded or carried away with that particular diagnosis. Keep your mind open and think a bit laterally also, that it will be helpful, because
Yes.
you may never know the actually given case may be a bit different than whatever expert is actually giving you a hint. So please be open and present nicely. You have so far covered very nicely all the points, and best wishes. Thank you, sir.
Thank you, sir.
Kanagal, sir.
Sanjay, if you have to carry
Yes,
out
sir.
a open biopsy for confirmation,
Yes, sir.
and what precautions you are going to take?
Sir, if I'm going to carry out incisional biopsy for the patient, sir, I would make sure that the incision is longitudinally placed, sir. And I would make sure I would control hemostasis, sir.
Mhm.
And even if I put the drain, I make sure that the drain would come out from the incision.
The drain should not be put, no?
The drain should not be put, sir.
Must
If I,
maintain
yes, sir.
good hemostasis, and drain should not be put.
And not raise multiple flaps, sir.
Yes, and the flap has not to be raised.
Raised.
Right. Okay. Is there any place for carrying out the isolated limb perfusion in your patient?
No, sir, not in my patient, sir.
Which patient?
Sir, in locally advanced and metastatic diseases for local control, sir.
Which is the tumor where there is a maximum use of the isolated limb perfusion?
Melanoma, sir.
Good. Right. You know, whenever you are answering such a case, that you must mention that this patient will be referred to the MDT.
MDT, yes, sir. Tumor board.
That has to come out.
Yeah.
Whenever you are telling about that, you have to tell that this will be referred there, and then we will decide about the plan of treatment. Is the biopsy done in your patient?
No, sir.
It has not been done.
No, sir.
Okay. Now, when you are doing a wide excision in this patient, what are the structures you are going to, vital structure you are going to lose?
Sir, in this patient, I would, we don't have the MRI report, sir. So we don't know what all vital structures are close by.
Mm-hmm. But think
Most
about that what structures can be lost in that.
Sir, here we can come across a posterior tibial artery, sir, and tibial nerve. This is all.
Yeah. But in this patient, even if you sacrifice those, will the patient have any deficit?
Sir, if we sacrifice the, sorry,
Like,
sir.
you sacrifice the posterior tibial artery.
Yes, sir.
What will happen?
Sir, and most of it won't go into gangrene, sir, because of the it won't go into gangrene, sir, because of the collaterals.
Yes. Anterior tibial is there, peroneal is there.
Peroneal.
So all they will supply that. So there may be some ischemia, maybe the mild ischemia may be there, but not to the gangrene part. Yeah, no? Right. So will you like to give in your patient the pre-operative chemoradiotherapy or post-operative one?
Sir, I would like to give preoperative radiotherapy, sir, for this patient. Sir, as sir, because so it's 9 centimeters. Largest diameter is 9 centimeters.
Okay.
Because there's better tissue oxygenation, sir, and the amount of radiation the patient would be getting would be only 50 gray, and the radiation toxicity, which it is close to the knee joint also, so we should be thinking about knee stiffness and any other fibrosis which will affect the patient in the further stages of his life, as it's only 24 years old.
Right. Okay. Can we stop here?
Yes, sir. I think, sir, any other comments? Professor Erbas Momin, sir, would you like to tell something before you take over the next case?
Sir, his presentation has been really comprehensive, and the other senior examiners' inputs are really valuable. And it's a learning experience for all the students on the channel. And regarding the radiation history, he has mentioned, but it has been discussed earlier also. So just to add to that, the radiation could be a localized radiation as a part of a therapy, or it could be an environmental radiation. And now there are instances where there have been nuclear leakages and radiations which are more associated with thyroid diseases. And this is a particularly in the peripheral limb, and the patient has clearly a history of no other treatment. So the radiation history was a bit of this thing there, but otherwise you have covered it really well. That's all.
Just one or two, Sanket.
Yes, sir.
We have already corrected you, but just to highlight the fact again, when you were asked the treatment part and all, you started with the radiation first and quoting Canada or something. But just to be on the safer side, first is what is the practice which is reasonably done in your hospital, number one. Number two, these trials, whether they appear standard book, standard whichever, you know that these things may help you in your theory exam when you write. But remember, operable when you are able to save the limb without compromising any nerves, vessels, muscles, deformity, you should consider a local wide excision, especially in your case like this. So there is then later is a different issue. I think you should be a little careful whenever you say that. Okay, that is one thing you always realize. Whenever you are talking about quoting some trials in especially forums in your Viva, in your MS examination. Best is what has been corrected to practice and see whether if you are sacrificing the limb, then yes, compromising that, yes, neoadjuvant and all that role will come, especially for sarcoma. I think this principle, again, a controversy of this is also there in the retroperitoneal sarcomas. Same way, whatever you are told about trials, same thing. But primarily aim is to do a surgery. That you should, I think, keep it in. Thank you.
And Sanket, one of the examiners has already told about this. In these kind of situations, MDT is a very good word that you should remember, all the students, because now everywhere it's multidisciplinary teams which decide about a lot of treatment related to oncology. Thank you.
Good presentation, Sanket. This is my excellent. Just 4 people are asking me questions with the 25, 30 years of experience. So just there is wisdom mixed with knowledge. So please take it. Thank you very much. You've done a very good job.
Thank you, sir.
Thank you,
sir.
8 on 10.
Thank you, faculty. Dr. Sanket, do you have any doubts to ask the national faculty? Any clarification doubts you have?
Sir, is there any center in India that is giving preoperative radiation therapy, sir, for such tumors?
We are attached to Karapete Institute, which is a big oncology institute. In a tumor board of a similar case presented over 2 months back, they suggested only surgery.
Thank you, sir.
They always felt operable tumor excise and go for radiotherapy. I'm just saying, this is for information. I don't know.
Thank you, sir.
As beautifully pointed out by somebody, follow textbook. All trials are only in institutes where they practice. Better to go by standard textbook descriptions. Thank you.
Okay.
Thank you, sir. Thanks for the opportunity.
Thank you, sir. And I wish the faculty to move on to the next case. I thank Dr. Sanket and Professor Amit for permitting me to present the case today. Now we move on to Dr. Abdesh from Vaidehi Institute, Bangalore. Sorry, Satyagiri Institute of Medical Sciences, Bangalore, to start his presentation. Professor Arsu sir, Erbas sir, and other senior faculty, please take over.
Okay, sir. Thank you, sir. Thank you, sir.
Abdesh, you're good to go, ma. Good luck to you. Please introduce yourself, your assistant professors, your HOD, and then start your presentation.
Good evening, respected teachers. Myself, Dr. Abdesh from Saptagiri Institute of Medical Sciences and Research Center, Bangalore. My HOD is Dr. Ramesh Sambat sir, and my unit chief is Dr. Kalagani ma'am. I'm presenting a case of a 46 years old female, homemaker by occupation, resident of Bangalore, who presented to the surgical OPD with chief complaint of swelling over the back of head for 3 years. Patient was apparently well 3 years back when she noticed the swelling over the back of her head while combing her hairs. Swelling was insidious in onset, gradually progressive. Initially, it was about 3 into 3 centimeter in size, and now progressed to the current side of 15 into 10 centimeter. There is no history of trauma, no history of headache, vomiting, seizures, no history of fever or pain, no history of skin changes present over the swelling or other swelling present in the body. Patient is a known case of type 2 diabetes mellitus from past 5 years, and she is on regular medication. She's also a known case of hypothyroidism from past 1 year, and she is taking tablet Thyronum for the same 25 microgram. Past history, no history of surgery in the past. Family history, no history of similar swellings or similar complaint in the family members. Personal history, patient consumes mixed diet. Sleep is disturbed due to the swelling. Blood and bowel habits are normal and no addictive habits. Summary of the case: patient is a 46-year-old female who is a known case of hypothyroidism and type 2 diabetes mellitus with painless swelling over the back of head for past 3 years with no history of skin changes or history suggestive of malignancy and no history of any other swelling in the body.
Abdesh, go to your first slide.
Yes.
I think we would like to see that one picture before you proceed, please.
Okay, sir.
One picture.
Yes, sir.
You can go back now.
Yes, sir.
Go to the next slide. So it's a, what do you think about this swelling?
Sir, considering the age of the patient and swelling is present from past 3 years, sir, I'm considering it as a benign swelling, sir.
Okay. Go to the next slide. Why have you asked for a history of headache, vomiting, or seizures?
Sir, swelling is present in the back of head, sir, to rule out the intracranial extension, sir.
But just as you said, okay, you are thinking of a benign swelling. So
Yes, sir.
if there is an intracranial extension, is it likely to be a benign or a malignant?
Sir, like dermoids is extended into the intracranial region, sir.
Okay. And looking at the location, do you really think it could be a dermoid cyst?
Sir, it is present at the back of the scalp, sir, and it is present at the line of embryonic fusion also, sir.
But you said that it started in the previous slide. You said that it started laterally and it's encroaching into the midline. It didn't start in the midline or at the lines of fusion. Had it been a dermoid, it would have started near the lines of fusion rather than later on moving on to the lines of fusion.
Yes.
Yeah. So you could have mentioned the other history which is related to a benign disease more early rather than putting the headache and vomiting and seizures before.
Yes.
And what other swellings are you concerned about in the body?
Sir, neurofibromatosis, sir, or multiple lipomatosis, sir.
Neurofibromatosis, would it present only like this one single swelling and nothing else on the face or the?
Less likely, sir.
Yeah. So is it that you are concerned about some other swellings, multiple lipomatosis? That is possible, but then you don't see one single large swelling like this. They are usually small in size.
Sir, to rule out the secondaries also, sir. Sir, swelling in the neck or other like abdomen. To rule out the secondaries, sir.
Okay. Which secondaries you will be more interested about?
Sir, thyroid, sir.
Okay. And she has some thyroid problem, you said?
Yes, sir. She's a known case of hypothyroidism, sir.
Okay. Okay.
Okay, Abdesh, what would be your differentials in this case?
Sir, first differential diagnosis is sebaceous, sir.
Okay, what else?
Sir, then lipoma or dermoids, sir.
Okay. Have you heard of a term called carry-on? Have you heard of a term called carry-on? K-E-R-I-O-N. It's a kind of a fungal infection which forms a kind of a lump on the scalp.
Yes, sir.
Right. Okay. Can it be a carbuncle?
Sir, based on the locations, most commonly, yeah, sir, patient is diabetic also, and most commonly the carbuncle occur at the nape of the neck, sir. And there will be
most commonly, but it can occur. Well, it can. What are the other sites? Most commonly, is it?
Yes, sir. Shoulder also, sir. Sir, but
what about other sites? Can
sir, there are no history of skin changes, sir, over the swelling, sir.
So, what's the carbuncle?
No history of fever.
What is a carbuncle?
Sir, it is
My
a
question is, what is a carbuncle?
Sir, it
What's
is a
a carbuncle?
superficial inflammatory superficial inflammatory swelling, sir.
Is this superficial? There's another.
Avdesh,
Yes, sir.
Superficial inflammatory swelling.
It is subcutaneous.
For definition of carbuncle, you're telling that is a definition. Superficial. What is that? What is it basically?
Sir,
see, this is just to give a. Don't feel bad. What we are trying to tell is, when a case like this is given, fairly straightforward. You know, we know that you are prepared, but obviously the question should be like this. It is definitely not carbuncle. Everyone knows 2 years duration and all that thing, but still, it is almost reaching that nape here, backside. So,
follicular infection, sir.
So at least you should tell multiple. What is the diagnostic pathognomonic feature of carbuncle?
Sir, multiple signs.
Multiple
sinuses will be discharging sinuses.
Sinuses. I think you have to see carefully, seem like openings. All right. So pathognomonic cribriform appearance. That's how we should say. So 2-year duration between the lipoma and sebaceous. You said sebaceous cyst or something like that. Which one you probably likely? You started by sebaceous cyst first and then lipoma.
Yes, sir.
What do you think sebaceous cyst will grow to this size in the scalp? Between lipoma and sebaceous, which one is likely to get infected more often?
Sir, sebaceous cyst.
Why lipoma doesn't get infected? That's why, you get such a huge ones, lipomas, very big ones. Sometimes they don't come in because relatively avascular structure. Why sebaceous cyst gets infected commonly?
It arises from the sebaceous glands and
there's an opening, there's an opening there, correct? So it trends. So obviously hair, combing of the hair, all these things, no? So it normally doesn't go to that level unless, so it's probably a lipoma is the most likely in this type of a situation here, right? Okay, just continue, sir, please.
This, what is Cox peculiar tumor?
Sir, it is one of the complication of sebaceous cyst, sir. Multiple sebaceous cysts are present, sir.
Yes. And what is the sebaceous horn?
So, it is the long-term complication of sebaceous cyst, sir, due to the deposition of keratin, sir.
You know, if you say it is the dermal.
So, ask you about Cox. Sorry, sir, please.
No.
What's a Pott's puffy tumor then?
Yeah.
Sir, it is osteomyelitis, sir. Osteomyelitis are most commonly frontal bone, sir, and due to which there will be subperiosteal abscess, sir.
So, this, if you give a
So
diagnosis,
how will you distinguish this from?
Okay, if you give a diagnosis of dermoid here, what type of the dermoid it will be?
Sir, sequestrated dermoid, sir.
Sequestration dermoid. You know? What is that? What do you understand by that?
Sir, it is due to the sequestration of the epithelium, sir.
Where?
At the line of embryonic fusion, sir.
And what is the commonest site of the dermoid, like this sequestration dermoid?
Sir, post-auricular or external angular dermoid, sir.
What are other types of dermoids?
Sir, implantation dermoid, sir. Tubular dermoid and teratomatous dermoid, sir.
Okay. And what is the material there inside these dermoids?
Sir, it can contain hair follicles, sebaceous gland or gland, sir.
What is that? You know, putty type of material is there. What is that? Have you seen a case of dermoid?
Yes, sir.
If you open the dermoid, you always get a cheesy putty type of the material. What is that?
Sir, a desquamated material.
Yeah, it is the desquamated epithelium which is there, you know, along with the sweat, the sebum, and all those things which are there to make it. How do you differentiate between a sebaceous cyst and a dermoid?
Sir, dermoid is present in the younger age, sir, and sebaceous cyst it will be present in the mostly in the middle age, sir. And on examination, sir, skin will not be pinchable, sir, in case of sebaceous cyst, sir. And punctum will be present in sebaceous cyst, sir. And most common sites for dermoid is external angular, post-auricular, sir, or in the midline, sir. And on examination in sebaceous cyst, there will be yielding signs, sir.
Okay. Okay, carry on, yeah.
Shall I proceed?
Yeah, please go on. Yeah.
General physical examination. Patient is moderately built and moderately nourished. Patient is conscious, oriented to time, place, and person. Vitals of the patient: pulse rate was 86 beats per minute in right radial artery. Blood pressure was 130 by 86 millimeter of mercury in right arm supine position. There was no pallor, icterus, or generalized lymphadenopathy. Sir, these on inspection, a solitary swelling of approximately 15 into 10 centimeter present at the occipital region. Vertically, it was approximately 5 centimeter from the vertex, and it was reaching till the occipital protuberance. Horizontally, it was extending approximately 2 centimeter from the left mastoid process, and it was crossing the midline 2 centimeter to the right of the midline. Shape of the swelling was ovoid. Surface appears smooth, and borders of the swelling was well defined. Skin over the swellings are normal, and no visible cough impulse or pulsation. These are the pictures, sir. from lateral, sir, and from posterior aspect, sir. On palpation, there was no local rise of temperature. Swelling was non-tender, present at the occipital region, horizontally 3 centimeters from the left mastoid process, and it was crossing the midline 2 centimeters beyond the midline. Vertically, it was extending 5 centimeters from the vertex and reaching till the occipital protuberance and 2 centimeters below to the occipital protuberance. Shape of the swelling was ovoid in shape, and it measures 19 into 17 centimeters. Surface of the swelling was smooth, borders were well defined, consistency of the swelling was soft. Fluctuation test was positive, and trans-illumination test was positive, sir. Swelling was non-compressible, no cuff impulse, and skin over the swelling was not pinchable, and swelling was not fixed to the deeper structure.
Abdesh, you said trans-illumination negative, right?
Sir, positive, sir.
Really, you just go through that?
Yes, sir. So typing mistakes, sir.
Is it positive?
Yes, sir.
Okay.
Yes, sir.
Proceed.
Sir, on percussion, dull note was there. On auscultation, no bruit heard. An examination of the regional lymph node was normal. Movements at the neck was normal, sir. And on systemic examination, per-abdomen findings, per-abdomen was soft, no non-tender, no organomegaly, bowel sounds were heard normal. On respiratory system, bilateral normal vesicular sounds were heard. And examination of the breast was normal. On cardiovascular system examination, S1, S2 are normal and no murmurs. So this is the trans-illumination test, sir.
This is the way to carry out the transmission test?
Sir, sir, we should put illuminoscope, sir.
Huh?
We should put illuminoscope, sir, on the other side.
No, when you are doing a transmission,
Yes, sir.
you have to see exactly opposite side. Now here exactly opposite side will be the skull. So
Yes,
you
sir.
cannot see from that.
Yes, sir.
So you have to put the lights on the side.
Yes, sir.
And then you have to see it from the other side.
Yes, sir.
So
Usually,
is the transmission positive, or this is just a glue which is there, or the glare which is there?
Sir.
I think this is not transmission positive, because once you make that physical sign that the transmission is positive, then
Yes,
everything changes here.
Yes, sir. Yes, sir.
Suppose
so
if you
just a glare is there, not the transmission.
Okay, sir.
But it appears to me it appears positive only, Sanket, Abdesh, because the entire area, if there is a spread of conducted light, it should be for some distance. But the entire swelling as like a globe, it is, and you have done it in a dark room. As Sir rightly pointed out, you should have kept it on the perpendicular. It should not be at the same side. It should be at least 90 to 180 degrees on the other side. Then only the conducted light will not be seeing a conducted light. Okay. So I think you need to mix and see what is. And in this case, to me, it looks transformation positive. What is the possible? Suppose if you take as a transformation positive, what is the possibility?
Sir,
this is a very important point which you are saying. Very important point. Because as Sir rightly said, all the other swellings transformation will be negative. Your dermoid, sebaceous cyst, all Y. They are all transformation negative Y.
Sir, content is different in all these swelling.
What are the criteria for transillumination to be positive?
Sir, cystic swelling, sir.
Like, what is the conditions, physical conditions for transillumination to be positive?
Sir, fluid should be there, sir, inside the swelling.
Yeah, I understand that. You should always see the wall should be thin and the medium should be clear.
Yes,
wall should be thin and the medium should be clear. You have hydatid seat inside the abdomen. Can you just go and do clear cyst inside, lymph cyst inside, deep inside the abdomen, rectoperitoneum? Can you check? You can't. The wall should be thin. Only subcutaneous swellings, you can see transformation. The medium must be clear. What is the medium? The fluid within the cyst must be clear. So it's always a positivity status in lymph cyst. Classically, lymph cyst, cystic ergoma, any other lymph cyst has got a clear fluid. Whereas sometimes in very thin seroma, you have some transillumination positive, very thin seroma, organized superficial seroma. But otherwise, transillumination may not be a hydrocele. An uncomplicated hydrocele, when you have a very thin skin, suppose if you have filarial scrotum or a thick skin because of chronic stretching, you may not have that positivity. In a clear, uncomplicated hydrocele, you may have transillumination positive. So, to be positive, to have transillumination, the skin should be thin and the medium should be clear. Scalp's skin is very thick skin. It's very difficult for you to demonstrate transillumination on that scalp skin. Okay. Yes.
Okay.
What is?
I have made my room darker.
Yes, sir.
Yes.
Can you see this? I am putting it light against my tip of the thumb. Can you see that all glare?
Yes, sir. Yes.
So do you think it is transmission positive?
Yes. No, sir.
That's what I am saying that. Okay.
Yes, sir.
So for transmission, you have to see at right angle to that to say that the transmission is positive. Because always there will be glare will be there. When you put a torch, and especially in this patient, you are pressing the swelling there.
Okay, sir.
Okay, with your torch, you are pressing that.
Yes, sir.
And that's why you're getting all the glare all around that.
Yes.
Okay.
Okay.
Why we are discussing so much about the transillumination is the swelling which you are showing. If it is transillumination positive, there are very few swellings which are going to present like this. One differential could be a lymphangioma. And apart from that, I was just checking it up. Some eccrine cysts of the scalp, which are basically arise from the sweat glands, can be transilluminated positive. But I don't know whether you would get this kind of a swelling. And the way it is appearing, the swelling is appearing, it appears as if it's a lipoma. And that's the reason all the examiners are quizzing you so much about the point of transillumination, because the entire thing changes. And there are not many swellings which are going to be transillumination positive over there.
Yes, sir.
Okay, meningocele, na?
Yes, sir.
Though this may not be the age for that, but if you get a transmitted swelling like that, meningomyelocele or meningocele which is there, encephalocele is there, all those things will come in picture.
Yes.
Okay.
Yes, sir.
Right. Okay, go ahead.
Sir, this is the test for cough impulse, sir. Cough impulse was negative, sir.
Cough impulse is
negative, sir.
negative.
Yes, sir.
What are the swellings which can give rise to cough impulse?
Sir, when there is a intracavitary communication, then cough impulse will be present, sir. In case of hernia, sir.
So hernia is one. Yeah, tell other causes of cough impulse.
Sir, dermoids is, sir, if there is intracranial communication, sir. Then
usually not, because the connection which is there is very narrow. So hardly a dermoid cyst can cause the cough impulse. Anything else?
Sir, in thorax, sir.
No, in the head.
Sir, meningocele, sir.
Yes, okay. Neck.
Laryngocele, sir.
Laryngocele. Chest.
Empyema thoracic.
Which empyema? Which empyema can give rise to cough impulse?
Which empyema necessarily will give you cough impulse?
Empyema necessitans, sir.
Yes, that's right. Yeah. Okay. Abdomen.
Sir,
Any-
sir.
Okay. Limb. Can you get a cough impulse in any limb swelling?
So, saphenaveric, sir.
Saphenaverics, you know?
Yes, sir.
Yes.
To be precise, any swelling which is in continuity with the body cavity, when there is a cough, there is a rise in the pressure in the closed body cavity. That will lead on to cough impulse. So all the swellings which you mentioned, all are directly or indirectly in communication with the body cavity. That is why you get a cough impulse and all that. So if they're not in a limb which is other than saphenaverics, rest of the swellings are not in continuity with the cough impulse. So the criteria to be cough impulse positive, the swelling in question must be in line with in continuity with the body cavity, so that the positive cough pressure is transmitted to the body cavity. Proceed, Abdesh.
What are the types of cough impulse?
Sir, expansile cough impulse and transmitted cough impulse.
So give the example of the expansile and transmitted.
Sir, transmitted cough impulse in case of any aneurysm, sir, and expansile cough impulse in case of hernia, sir.
In case of?
Hernia, sir.
Yeah. So if there's a hernia is there, which is other swelling which can give the transmitted cough impulse, and you may be confused that whether it is a hernia or something else.
Sir, saphenaveric, sir.
Yes, saphenaveric, something else. At the root of the scrotum. Varicocele, no?
Yeah, similar to saphenaverics.
Varicocele. Yeah.
Yes,
Okay.
Okay, what is the difference between, sir, actually asked you, what is the difference between a cough impulse in a hernia and propulsive and expansile? You should say propulsive and expansile. If you keep both the fingers of hand in front and behind, the fingers will get separated apart. That is why you call it as expansile. Fingers are expanding. Normally, every human has subcough impulse in the superficial ring. That is not normal. You and I have. That is the mechanism by which the pressure is transmitted. That is not cough impulse. Only when the cough impulse is expansile, you call it as a positive cough impulse. Otherwise, a normal cough impulse will be present in the inguinal region. That is to reduce the intrathoracic pressure. It's a natural mechanism of avoiding rise in pressure inside the abdomen. Proceed.
Sir, this is the test showing fluctuant, sir. Swelling is fluctuant, sir.
Can you just explain the mechanism of testing fluctuation in a small swelling and a large swelling?
Sir, in large cystic swelling, sir, fluid will cause the pressure over the other side of the swelling, sir, which will move apart the fingers, sir. In case of small swellings, the central will be solid, sir, and in the periphery it will be cystic, sir. So there we have to do Paget's test, sir.
Good. I'm asking you, what is the principle? How will you do test first? Just I'm asking you to do fluctuation for a hydrocele. How will you do the first? First, what will you do? Step 1, step 2, like that. The way in which you do it.
Sir, from one hand we have to fix the swelling, sir. With
first, very important, very good. You have to make the swelling tense.
Yes,
fixing, not fixing, make it tense.
Yes,
You're not losing it. Fix it tense. Next one, next.
Sir, with the thumb and middle finger, we have to fix the swelling, and
okay.
And from other hand, we have to like the other examining hand that we have to put on the other side, and with the index finger we have to press it.
Yeah, the finger which is pressing is called a displacing finger. The finger which is getting displaced is called a watching finger. You press at the lower pole and feel at the upper pole. The lower pole pressure giving finger is called a displacing finger. The upper one which is displaced is called a watching finger. That's called a, like, take it like a typical example is a water-filled balloon. To take that and press at one point, to be positive, the wall should be elastic. The criteria for a fluctuation to be positive, the wall should be elastic. In a hydrocele, uncomplicated, you have fluctuation. When it is complicated by calcification and thickening of sac, you may not have the fluctuation elicited. So when there is transillumination positive and fluctuation positive, you take that case as a case of uncomplicated hydrocele. When they are not there, it's a complicated hydrocele. As you rightly said, Paget's test in a small swelling, as per the principle of physics, a solid swelling will be most hard at the center. A cystic swelling will be least hard at the center. A solid swelling will be most hard at the center. Core, that will be hard. The periphery will be, so whereas the cystic will be least hard at the center because the fluid will go and hit against the wall to cause surface tension. That is why you press at the center. You have to fix again with 2 fingers and then press with the finger of the other hand or the same hand also. That is why that is the principle on which Paget's test is based on. Yes, Abdesh, you can proceed.
Yes,
Abdesh, can you go back and show the video of fluctuation? And can you just elaborate on fluctuation and cross fluctuation?
Sir, in fluctuation, sir, when we press from the one side, sir, after fixing the swelling, sir, the other watching fingers will displace, sir. Cross fluctuation will present when swelling is present at the 2 different regions, sir.
And are you aware of any swelling which would be fluctuant but not cross fluctuant? And which is not a liquid swelling or a
Lipoma,
cystic swelling?
lipoma, sir.
Yeah, because over here you are not doing a cross fluctuation. You are doing a fluctuation because your index finger and thumb of one hand is pressing and the displacement is seen on the other hand.
Yes, sir.
So if you're going to do a cross fluctuation, maybe the result might be different.
Yes, sir.
And lipoma is a differential in this swelling.
Yes, sir.
Abdesh,
Yes, sir.
Just to see carefully what you are doing is actually you are pressing on one side and with your index and thumb on the same hand. Did you observe that? You should do it at a right angles too, you know.
Yes, sir. 2 separate angles, sir.
You should see you are standing behind there. Whatever you are pressing with your right hand, and you are to appreciate on the other hand.
Yes, sir.
What you demonstrated as Sir Elvis also mentioned, it has to be, you know, it has to be perpendicular to the line, you know, both like this. You understand?
Yes, sir.
Then, so that is what is the standard method.
Yes, sir.
I hope it's clear. Because both the transillumination as well as fluctuation becomes the most important thing for you in your exam here. Because most of you people will have the diagnosis, ultrasound diagnosis, whatever it is. So basic things I think you should be clear. What is the difference between reducibility and compressibility? You are written there somewhere, compressibility.
Sir, compressive swelling, sir, when the pressure is put over the swelling, sir, without any external force, it will appear again, sir. While reducible, sir, when the pressure is put from above, sir, with external forces, that swelling will appear again, sir.
Without any counter force. So what happens in a hernia, I think all of you know, it goes in reducibility, and when a patient coughs, it comes back. So just give me one example of classical compressibility, compressible swelling in the neck here or wherever it is.
Lymphangioma, sir.
Lymphangiomas, more than that, vascular malform, hemangioma actually.
Laryngocele, sir.
What is that?
Hemangioma.
Meningocele, you said, I think, got impulse on cough. No, it has been asked to you, expansile impulse on cough, transilluminant swelling. So, do you consider meningocele here?
Sir, less likely, sir, considering the age of the patient, sir.
What is the duration of the swelling?
So 3 years, sir.
Yeah,
3
3
years.
years. Nothing.
So you said no cough impulse, no? No cough
Yes,
impulse.
yes, sir.
Can it be a dermoid cyst itself? Might have been present as very small and going on for, so it can occur so much like this. What is the diagnostic feature of a dermoid cyst?
Sir,
Sorry?
bony indentation will be there, sir.
So did you mention that in your findings?
Sir, it is not there, sir.
No. It is not there, you should mention, because see, you have been asked that question: midline, dermoids, lipoma, hemangioma. So all this you are indirectly trying to rule out one by one. You said no reducibility, no compressibility. Trans-elimination is the only one key controversial thing, whatever it is here. So you have to mention what is the difference between bony erosion and bony depression. Why do you get bony depression in dermoid cyst? And what condition?
Sir, long-term swelling, sir.
Abdesh, in reducibility and compressibility, Sir has initiated, I wanted to share. Compressibility, you cannot make the swelling completely disappear because it is either AV arterial malformation, venous malformation, or a lymphangioma. You can only disclose the fluid from inside so that the next pulse, it automatically gets refilled. Okay, you don't have to do. Once the pressure is removed, automatically. Second thing, the most important point is you will not be able to completely make the swelling disappear. That is a valid point. In a compressible swelling, you will not be able to make the swelling completely disappear. They are not in continuity with any body cavity. Reducible swelling, they are in continuity with the body cavity, and you can make them completely disappear. Can you understand? Take a case of hernia. You can make it, if it does not become reducible, then you call it a complicated hernia or an irreducible hernia. Can you know that? So that is the difference. A normal uncomplicated hernia, reducible, able to reduce it completely. Whereas complicated, it is not possible. Whereas in a compressible swelling, you will not be able to reduce the swelling completely. No force is required to make it appear. Okay, the fallacy is a direct hernia, or when a patient is, when in a hernia, when the patient gets up, students ask, sir, when they stand up, it is appearing. When you stand up, gravity is acting. That is a force which is making it appear. Can you understand? Gravity is acting. Something is acting to bring it out. But a compressive swelling, you don't have to do it. It gets filled automatically, and you will not be able to make the swelling completely disappear. Okay.
So I just, sorry, I got disconnected. Just wanted to ask you, what is the difference between bony depression and bony erosion? Bony depression. Hello, Abdesh, you are there?
No, sir.
You are there, no? In dermoid cyst, you get bony depression, no? Correct? Indentation, whatever you said, correct?
Yes, sir.
Why do you get it? Bone is mesodermal element.
Yes, sir.
Correct?
Yes, sir.
Dermoid will congenital required, this, especially in these locations.
Sir, congenital, sir.
So it starts from the fetal life itself, embryonal life, where bone is not yet formed. So by the time child is born, there's a small dot-like thing. So that's how you get that bony depression, angular dermoids. So however big the lipoma, benign ones, or even a sebaceous cyst, they will never produce a bony erosion in adults like the depression. That's the important thing. So if you look for a bony depression or erosion, obviously we use the word in malignancies. Like you meant, I think the first case or somewhere, thyroid, follicular carcinoma and all that thing has been mentioned.
Yes.
Did you do a pitting test in this patient? You know what is the pit test?
Sir, yielding or molding test, sir.
So have you done that?
Sir, I have not.
So these are the things which will differentiate between a sebaceous cyst, dermoid, and a lipoma.
Sir, video I have not put, sir.
No, but did you check for that? Is this spelling
Yes,
fitting
sir.
or not?
Fitting, sir.
It is fitting.
Yes, sir.
So if it is fitting, then what does that mean? What is the first diagnosis?
Sebaceous cyst, sir.
And if we
And you say it is transilluminant? lot of because we can't examine the swelling, but you have to be careful.
Sir, fluctuation test was positive, so I did a transillumination, sir, like that, sir.
No, what I think indirectly, Dr. Khanna sir and all of us try to say, a lot of controversial things are in your case.
Yeah, a lot of
findings.
To break the ice, can I ask you, have you done investigation on this patient?
Okay,
to break the ice. CT you would have done, man. What is the finding?
Sir, X-ray of the skull is only done, sir.
Why, man? You have such a big controversy. You have a transillumination, positive swelling, big on the scalp, and larger than 8 centimeters, 10 centimeter. Is this a thing?
And for CT scan, sir, patient was admitted yesterday only, sir.
Oh, sorry. I am very sorry. I misunderstood.
There is absolutely no harm in sending for a simple ultrasound, especially for
exactly. Exactly.
You understand?
Easily could have been done. Scalp ultrasound with the high resolution probe, it's very, very useful. Easy. Okay, ma'am.
Okay, let us sort out amongst ourselves, Jana. Dr. Shenoy, what is your first diagnosis?
Sir, I still feel it is lipoma, sir. That's all.
Okay. Dr. Arsu, what is your diagnosis?
Sir, my diagnosis could be a cyst in the scalp, sir.
Which cyst?
Could be a sebaceous cyst, sir.
Okay. Dr. Arbaz?
Sir, I'll just complete, sir. That could be a pilar cyst, sir, arising from the hair follicle, tricholamel cyst. Only reason is, 7 days back, I operated a woman in the right parietal region of a swelling which is 8 centimeter, referred by a neurologist after a CT scan, which turned out to be a cyst, pilar cyst. Very large one, 10 centimeter, but on the right occipital region. I was surprised, such a big swelling, 10 centimeter in the occiput, in a 35-year-old lady, almost similar, but the location is different. This is my view, sir. Lipoma is my next diagnosis.
Lipoma, what do we think?
I feel it could be a lipoma. Some of the tests which he has done, they give an appearance as if it's a lipoma, because there are questions raised in the way those tests are done, like transillumination, which could be confused in a lipoma. At the same time, the fluctuation which was done was not a cross fluctuation, and this kind of a fluctuation can be there with a lipoma. So looking at those things, I feel it could be a lipoma.
Okay. I will put my coin on the dermoid cyst here. Okay. I will keep my first diagnosis as dermoid cyst and the second as the lipoma. Why dermoid cyst? Because this in the midline, it is there at the suture line, which is, and the look of that, the look of this looks like it's just like a globular type of the swelling like this. So that look which is there is probably, so that's why I'm keeping a possibility of the dermoid here. So, but I think Dr. Kanagal will tell us next time that what it is.
Share our phone number, please share your diagnosis after a radiology and biopsy.
Next week we will, once the case is operated, then we will
yes,
share.
Sir.
Yes, sir. Adesh, directly the message is very clear. Lipoma, dermoid cyst, lymphangioma, meningocele, common questions, common diagnosis which will be asked. So please do not try to include a very, very rare diagnosis and all that thing in this situation, especially in your exams. That's what it is. When an examiner asks you what else, yes. But you should also know the art of speaking and to rule out.
Yes, sir.
I considered this one, but probably these are 1 or 2 findings are not supporting.
Yes,
I considered this, But these are some findings. So this happens. This happens. That's why we ask you some of the differential. But situation and this transelimination and fitting, we are not there to examine this. We are not there. So that's what it is. Okay, sir.
You have done a good job. The only thing is, the trans-elimination, you confused yourself and you confused all of us. Nothing wrong in it. It led on to some good discussions. That's all I can say. Please share your radiology and post-surgical pictures with us, I think through Kanagavel, sir.
Yes, sir.
Even though it is a very, very rare physical finding, but including, I have put in a comment, Balian law, latest edition also gives lipomas can also be trans-eliminated.
Exactly, sir.
Don't want to say it loudly because it is not a common finding.
Sir, I have seen that, sir. I strongly support, sir. I have seen got confused. Yes. So we are not teaching students like that, but it can happen, sir.
So classically, if you read soft lobular edge slips and all that thing, but you should need to know in the scalp. Scalp, the layers are quite tense. SCALP, the loose area tissue. So don't expect it to edge slipping, all that thing to happen in the scalp. So I'm not trying to say it is transluminant based on how you have demonstrated. That is a different issue. But as a DD, when you give few diagnoses to be kept in.
I think I would like to add, sir, all of us gave a cyst as a first diagnosis, and all of us accomplished lipoma as our second diagnosis, sir. Because we have seen sometimes trans-elimination in fat also. I've seen that very rarely happening. Still, it's possible, though it's not a solid tumor, it can still happen. Sorry, any simple test which can throw light on this? CT scan, before CT scan?
Sir, for confirmation, sir?
Yeah, simple test. FNAC you can do straight away. The moment you would have done a FNAC, straight away that showed you what is that. Put a needle, you would have seen. Nothing wrong in putting a needle and seeing, okay? Whether many of our residents do without informing us. They put needles and diagnose. And so you could have done that. Did you do that? First of all, I wanted to ask you out of puzzle to conclude, not revealing us.
Sir,
you attempted putting a needle, man. Tell me honestly. Tell me honestly, be honest. That carries more mark than your knowledge.
Yes, sir.
What was the finding?
Sir, lipoma, sir.
Yes. How did you know that? You sent it for FNAC.
Yes, sir.
Yeah. Sir?
So what was the FNAC report? What did you say?
Sir, it was done outside, sir, 2 years back, sir.
Yeah.
So what pathologist wrote?
Yes, I would really thank you for presenting this, and some of the videos which you made of examination, illumination. These are common things, and you might have made it in a way which is not the accepted way. But even then, it's a learning experience, so don't feel bad about it, because by doing that, a lot of other people are going to learn. And if you do the imaging, if you get the reports, you can go to the YouTube link of this channel, which is being, everyone is being, and you can put it in the comment section where you see this presentation. So people who are watching, they also would be interested in knowing this, and they would be able to know about this.
Yes.
Sir, it's very rightly put it. It has to be the domain so that everyone can watch and learn. Okay. As sir said, lipoma sometimes can be trans-eliminant. I have seen, and I'm not able to support my point, but they are trans-eliminant in certain states, not always. Certain situations I have seen, especially when you have a very thin skin on top, very, very thin, very subcutaneous, you can have that. Yes. Is it fat lipoma fluctuant on? Are they can be fluctuant?
Yes, sir.
Yeah. What is that called? Pseudo fluctuation. Yeah. Fat is fluid in body temperature. You may have fluctuation type of feeling in a lipoma. Okay.
So if lipoma is there of the scalp, in which layer it will be?
Yes, sir.
in which layer of the scalp this lipoma will be?
Sir, loose areolar tissue, sir.
Okay. What are the other places where you can get the lipoma in the scalp?
It's a brilliant question, sir. Brilliant question, sir. They stick to loose areolar tissue and forget.
Like you find a very fixed swelling.
Sir,
Okay, it's a very, you are not able to move this swelling, but you still think it's a benign tumor is there. So where is the lipoma? In which layer it is?
sir, periosteum, sir.
Periosteal, good.
That subperiosteal. They almost feel like, hard osteomas. For that matter, even sebaceous cyst. Sometimes, scalp layers are so, small ones. When you feel, they feel like that.
So what are you going to do for this patient?
Sir, excision of the swelling, sir. Before the sir, X-ray of the skull is done, sir. It is showing no intracranial communication, sir.
Okay, so what are you going to do?
How reliable is the X-ray for demonstrating intracranial communication?
Sir, I'd like to do CT scan, sir. CT scan of the skull, sir. CT head, sir. Plain.
If you want to look at the intracranial communication, X-ray is not going to be really reliable.
Yes,
That's what I just wanted to point it out. Yes, go ahead. So CT scan, that you would be able to know if you have if clinically, if you are not very sure what exactly this is, then
Yes.
a CT scan would be a good investigation to know whether
Yes.
there is any intracranial communication
Yes, sir.
before you plan to take her up for surgery.
Yes, sir.
So basic investigations in this case would be basic investigations to do surgery. And then can you operate under local anesthesia? If so, what type of drug you have to give?
Sir, lignocaine with adrenaline, sir.
Is it sufficient for such a swelling, such a large volume swelling? Any other fluid where you mix 3, 4, 5 agents, 4, 5 agents and give, which can be used in oncological surgeries also, reducing the blood loss?
Sir,
Starts with T. Starts with T.
Tumescent anesthesia, sir.
Yeah, tumescent anesthesia. These are the cases you can do it under tumescent anesthesia because you can give large volume of fluid so that bloodless field can be expected, and you can do it under local anesthesia, whereas otherwise you have to give GA for this patient. It can be bloodless. This is what, even if you patient wants GA, you can always combine this with tumescent anesthesia. Having said that, what is the dose of local anesthesia? Local anesthetic?
3.5 mg per kg, sir.
Sorry, suppose this lady is 50 kg. What is the dose?
Sir, 1 ml contains 20 mg, sir.
Yes, good.
Then
Usually,
50 mg,
yeah, usually for a 50 kg woman, you can't give more than 8 ml. You
Yes,
can
sir.
say maximum 3 to 5 ml, go to the upper limit also. 60 kg, you can't more than 10 ml. 10 plus 10, you can dilute it by another 10. 20 ml is not sufficient. Suppose if you add adrenaline, what will happen?
Sir, dose we have to adjust, sir.
Yeah.
That is,
You can go up to 7 ml. We'll finish in 1-2 minutes. You can go up to 7 milligram per kilogram body. 5 to 7, 6 milligram you can take average. It prolongs the duration of action. It also gives a bloodless feel because of the prolonged duration of action. Slow absorption. You can give more dose and bloodless feel. The problem is it can produce a rebound bleed. Patient can go and have a rebound bleed. All this can be avoided in tumescent anesthesia. Okay, what will you do? Excision biopsy. Excision biopsy. You'll send it for biopsy, is it not?
yes, sir.
Yeah. Anything when you say, don't say excision. Always say complete with biopsy. Wide local excision biopsy, excision biopsy. She always says, my teacher used to say, surgeon biopsies, butcher exercises. So you should combine excision, biopsy.
Yes, sir.
I think that I have nothing to ask, sir. You've done a good job. I think the rest of all of you can just give a comment on, can just log out, sir.
So you can give plain xylocaine more or xylocaine with adrenaline. Which can be given more?
Sir, xylocaine with adrenaline, sir.
Okay. How much usually you can give in an adult? No, it is 2% xylocaine is there.
Yes,
How
sir.
much maximum you can give?
Sir, 7 per kg, sir.
No, like, there's a vial of xylocaine is there. How much is the usual amount in that?
10 ml, sir.
30 ml. No?
Yes, sir.
So the normal vial which comes, it's around 30. Not the ampoules. The vial which is there is around 30 ml. And 30 ml is also for the xylocaine with adrenaline.
Yes, sir.
So like if you are operating a patient with a hernia and you have to give the patient 70-80 ml of that has to be given.
Yes, sir.
So even if you make it 0.5%, the effect remains the same. So whether you give 0.5% or 1% or 1.5% or 2%, effect remains the same. So you can dilute with the normal saline and then you can give it, so you can have the more dose of that.
Yes, sir.
Practical, sir is giving you practical tip as a surgeon. I don't call anesthetist and I just take 10 to 15 ml of adrenaline anesthesia and add around 20 ml, make it 35 ml. You can even operate a larger swellings. The patient has to be cooperative, reduces the risk. The patient should not be a cardiac patient or a hypertensive, otherwise it will be in problem. Thank you, sir. I think it's can I go well, sir? I think it's
I think we have when the examiners are at conflict, the candidate should be given a clean chit now. Abdesh, do you have any doubts or issues to be clarified here?
No, sir.
Do you have any doubts to be clarified?
No, sir.
Yes or no?
No, sir.
Okay. So thank you, PGs. Thank you, examiners. Thank you, Arasu sir and Eppa sir for joining today as an invited faculty. Kanna sir, Karnakaran sir. I think people are already started leaving. They are tired already. And good these candidates. In fact, Abdesh was asked to come as a replacement only as late as yesterday night because the other boy who was supposed to present fell sick. And in spite of a very short notice, I think Abdesh coped up this well. And Abdesh
did a good job, sir. He doesn't look like a makeshift presenter. He looked like a good presenter straight.
Yes, sir. So, Abdesh, you please share the CT or whenever your other investigations are coming up. Preferably, if you can take some operative pictures and how the skin flap was fashioned, because the skin cover has to be, even though it looks like a stretched skin, many times people end up taking an eye of the skin and they end up having a very tight closure. So marking has to be very carefully and meticulously done before taking this patient for surgery. Ideally, if you can safely enucleate, then you fashion the skin for closure, because there are at times people end up doing a wide excision of the skin like an ellipse and they find very difficult to close the scalp. Scalp becomes, then the local anesthesia may not work. You may need a conversion, especially when you're doing these type of things. And be prepared to handle the bleeding. You should have adequate bipolar energy source, monopolar energy source, because at times this can be a very bloody operation if you are not getting the right planes. Very rarely happens, but then don't do in a small theater or something. These type of big lesions at times can be very profusely. Many times it can keep compressing the veins because of the stretch. So anywhere you touch, the getting in only will be a very painful stuff sometimes. And always keep one of your assistant professors or any of the chiefs standby if you are doing. It is not like a small cyst where you PGs can handle by yourself. That is my advice for if it is done in my department. And always keep the pre-medical, pre-anesthetic fitness done for this patient. Should there be a requirement for any conversion? Because many times these patients come up for local anesthesiologist and you will end up having problem if there is a handling thing. These are the precautionary things I'd like to add upon. Good luck to you. Keep us posted about the reports.
Okay.
Thank you,
And,
sir.
thank you, sir.
Thank you,
And
sir. Thanks a lot.
can we call a close, sir? Kanna, sir. Karnakaran, sir.
Thank you, sir.
Yes.
Thank
Thank you, sir. Abbas, sir. Thank you. Arasu, sir.
Thank you. Thanks a lot. Thank you.
Both Adesh and sorry, the other candidate, I think he has left already. Okay. So thank you and good night, everyone. We look forward to meet in the next Friday.
Good night.